But I'd like to open it up to the audience for some questions at this point. Yes, ma'am.
I'd just like to echo what's being said. And what I hear you saying is that incentives can work, but they're not going to work for everyone. And often the highest end users, people spending the most Medicaid dollars, are the hardest to incentivize in some ways. But I would say, back to something that David had said, I think that peer services are a pilot program, but there is some demonstration projects, especially in New York City, that are demonstrating that they do have success rates with high-end users. And that you can even incentivize a peer in some ways. So instead, cash isn't going to work for everybody. Increased smoking cessation, accessibility isn't going to work with everyone. But someone that is available to sit with someone, talk about medication compliance or treatment compliance, or not even coerce in that way, but just how can you take personal responsibility around participating in your treatment. And what I would say is that the state recognizes that that is an important and valuable service, but the state has yet to fund that service. The state is sort of pushing it back on managed care to say, we think this is important. We might incentivize you for including it, but we're not telling you how to fund it. And I think that's a message that needs to change. If we recognize that that's a valuable service and one of the continuum of what could be an incentive for people, it also needs to be funded.
It's little things that I think we need to be creative about. I know a colleague of mine was telling me about a program in India where there's a mandatory savings program for people to send their children to educational programs. And they found that something as simple as putting a picture of their child on the envelope in which they were saving dollars made a huge difference as to whether they complied or didn't comply. And that gets back to the whole issue of behavioral economics that David brought up, that I think is really important, and HHS has delved deeply into this whole field of behavior and economics. It's making the right choice easier to make, I think, is one way to summarize it. And I think there's a lot of learning that can be done around that that are the kind of incentives that do work because they're personalized.
Yeah, I'm all for incentives. I think Jim is right that the tax on tobacco is not an incentive. That's a penalty. And so is the mandate that you purchase health insurance.
Yes, sir.
Certainly the political discussion would be fascinating, but that would take 2 more hours on how to implement this. But one practical question. We have 58 counties, including New York City. We go from Long Island to Buffalo to the North Country. How do we remake our system and take it to scale at the same time without spending more money?
Well, it's a fair question, and in the long run, the states that have tried this have had to do some investment up front, but they've had payback on the back, and we have that strange system, as you know, that's not unlike a lot of states where we have local administration and state supervision, which I think probably does make the construction of some of these things more difficult. But then again, the construction can also be more localized and be, adhere more to the norms of the community and what would work as far as that. But I don't think states are embarking on this, or countries are embarking on this because they think it doesn't ultimately save them money. That's the goal. I mean, one of the most programs that Opportunity New York City was modeled after was Mexico's program called, I don't speak Spanish very well, Oportunidades. And they have seen remarkable outcomes among children and clinic visits and all the kind of things that they intended to do, and they saved money.
I guess I'm not going to get into the state takeover of Medicaid. I'll let other people talk about that. But it does seem to me that the locally administered nature of New York system allows for another application of the principle I said of replicate what you know and test what you don't. And that is that there are things that are well enough established that the state ought to make them uniform requirements or expectations in the Medicaid program, no matter where you live in New York State. And then where that things don't rise to that level, the counties, as we've said in many other areas, provide a wonderful laboratory to test and see if we can actually build the evidence base and establish effectiveness, and then move things into the sort of uniform standard. So I think, again, there's sort of a 2-tier process there in terms of deciding what's well enough established to be a uniform state requirement or expectation, and then what isn't, and where do we want to turn to the counties as the laboratories of experimentation so that we can learn new things.
Well, increasingly, we've made the judgment in New York on Medicaid to make it a statewide program, and the notwithstanding the financial obligations and the way that's apportioned, it's getting to a point where the Medicaid program is essentially going to be a state-operated, state-supervised program without as much involvement at the local level, and for good or ill, there will be some loss as a result of that. I think in terms of the ability to do regional experimentation, to have programs that deal very much more uniquely with the issues involved in local communities, but I think as a practical matter, it is essentially a fait accompli.
I agree, and I think that's where we're going. I mean, I sometimes raise issues with Jason Helgerson and the state's direction, but the mayor and Deputy Mayor Gibbs and myself are enthusiastic supporters of the redesign of the system and pleased with the early results, especially with regard to the staying within the cap. And I know that their favorite slide has been, or was at least last summer, that they felt the restraint in Medicaid spending that happened in New York contributed to bending the national cost curve, and that's a good thing. So I agree. I also think one of the advantages of it is that there's no the ending of the dual responsibility allows the sort of escaping blame and fault, and then sort of you're pointing at the other guy, and then you don't anything ever gets resolved. Here we now will have a strong state leadership of the managed care movement.
Yes, ma'am.
I think as somebody who sort of represents the A counties across program areas, with due respect to my former big bosses, I think we do need to think about separating the TANF population from the rest of Medicaid, and we know that there's a big, who are we aiming at? The TANF model has its pros and cons. I know, I lived welfare reform, I taught welfare reform. It has its pros and cons in terms of personal responsibility, but that's only a very small subset of Medicaid, up to the rest of 138% of poverty, and now we're talking about up to 400% of poverty into the state system. This difference between the TANF people and the 138% of poverty people, we know there's a lot of overlap with the food stamps population. I think if we can really work on doing things with food stamps in terms of what you're allowed to buy, I think that in itself is without forcing personal responsibility on the person. If you can't buy Pepsi and Cheetos with your food stamps, or for that matter, high-end things like, steak and lobster, and we work with the programs such as FISNEP to educate the people, I think a partnership there could be very valuable.
I think that's an interesting point. Maybe we get the Tom to respond. In a sense that as the government increases its role in the support of these populations,
it's going to take a greater interest in how those resources are used. It's just inevitable, whatever we call it. So Russ or the rest of the panel, could you give us some thoughts on that?
Well, I think on the specific point that was mentioned, it's a critical one. In reality, former health commissioner and rest his soul, Richard Daines, who was one of the architects of the waiver to the Department of Agriculture urging that the food stamp benefits not be allowed to buy certain products, particularly sugar-sweetened beverages. He had been a practicing pediatrician in some of the poorest areas in New York City, and the mapping overlay of the incidence of obesity and diabetes and the consumption of certain products in New York City was just absolutely startling, and in the poorest neighborhoods of New York City. And yet, the strange alliance between anti-hunger advocates who viewed the ability to purchase anything with food stamps as being something that should be allowed, and the beverage industry that certainly knew that the amount of money they generated from purchases of those products. So we really had a collision of public health and individual rights on that very issue. But I think we have to come to grips with it. I think the Department of Agriculture made a terrible mistake in denying that. It was a 2-year pilot, 3-year pilot test to see if it made a difference. You would have learned from an evaluation whether people simply substituted their own money for food stamps and bought the same products that were unhealthy. But you know, that was totally an ideological decision. And so more and more things like that, I believe, are, you know, they're critical. I mean, if we're serious about not spending public dollars counterintuitively to the purpose of those expenditures, then that's a normal thing to test.
I would just only add one thing, and that is the Medicaid program and the TANF program have been two entirely different programs for a long time. In New York City, we have 2.9 million Medicaid recipients or beneficiaries. We have 360,000 cash assistance recipients. They're not the same. They haven't been the same for a long time, and they're totally different programs. And people access Medicaid in 100 different ways, and not including necessarily the welfare office. So we're well down the path in seeing different populations.
Yeah, I mean, I also was very sorry that the USDA was not open to looking at some experimentation around this. I think if there's, you know, given the size of the investment that's going into this, given the public health consequences of the way people are using their benefits, I think they need to do that. The one thing I guess I would say, though, on your the way you expressed the point was, I think we need to clearly distinguish between, in that case, potential limitations based on public health impact versus potential limitations based on a sort of moral sense of what people should or should not be able to buy with food stamps. I think what the food stamp advocates are concerned about exactly is the slippery slope from sugar-sweetened beverages to steak and lobster, and people making judgments that those people shouldn't be allowed to eat those things, even if they have nutritional value. So I'd be very careful about distinguishing the one from the other.
All right. Well, please join me in thanking Russ Sykes and the rest of our terrific panel today.